next speaker, Dr. Soosan Jacob, and who is the director of the Dr. Agarwal Refractive and Cornea Foundation, and with a huge experience. And she is going to tell us something very important, which is quite a rare entity now. How would I treat epithelial ingrowths? On to you, Soosan.
Thanks so much, Chitra ma'am. I'll just start with my presentation immediately. This is on epithelial ingrowth, and of course, epithelial ingrowth is very easy to distinguish from other interface complications. We all know how it happens. It could happen due to primary implantation during surgery, but the more common, mechanism that it happens is that the edge of the flap is not stuck properly, or there's a small gap, and a fistula develops under the flap, which allows the epithelial cells to grow into the interface. Of course, the incidence is decreased with the femtothoracic and smile as compared to microkeratomes. The risk factors, as I just said, microkeratome flaps. Another risk factor is hyperopic LASIK after radial keratotomy, and a common one is intraoperative epithelial defects. You also major causes flap lifts for enhancements or any other purpose. So that's another very important causative factor. You may have mild, clinically insignificant epithelial ingrowths, which are defined as those that are within 1 to 2 millimeters of the flap edge. And if they're really not causing any problem, you can just observe them. And especially if there's no fistula associated with it, which you can make out just by doing a fluorescein dye staining. If you have complications, of course, you might want to treat. So it's been staged, as I just mentioned, within 2 millimeters, more than 2 millimeters, and those where you have other complications such as, when it extends into the visual acuity, visual axis, decreasing the acuity, it extends to the edge of the pupil. Again, that can cause glare. You can sometimes have topographic abnormalities due to the epithelial ingrowth, such as localized flap elevation, irregular astigmatism, and so on, and decrease in the uncorrected and best corrected visual acuity. And of course, in the last stages, you could also have induced keratolysis and focal flap lift. So again, a lot of techniques have been described for treating epithelial ingrowth. Generally, of course, like I said, you can observe for peripheral epithelial ingrowths, which are just static, which are not progressive, and which are not causing any visual symptoms. But if any of these things are happening, you would want to lift the flap and remove the epithelial cells from not just from the bed, but also from the posterior surface of the flap. And then you can replace the flap. You can, of course, also apply adjuvants such as mitomycin C or alcohol, or sometimes combine it with a PTK. And the other additional measures, as also just described by Dr. Sujata, was flap suturing, fibrin glue, and so on and so forth. That's basically to kind of avoid a recurrent epithelial ingrowth. And you can also do a YAG laser treatment. So I'll just show a couple of videos. Here was a case who had a partial, it was referred to us. She was a 21-year-old who underwent LASIK for minus 2.75 diopters OU. The interesting thing was she had a free cap in the right eye, which was replaced with the primary surgeon. Laser ablation was not done. So they didn't really perform the excimer laser. It was just a free cap replaced, and she was referred 1 month later for a displaced flap. And this is how I saw her. And so we took her up for surgery. This was a topographic map of the patient. Maybe I'll just, and this was the anti-segment OCT, which definitely showed an epithelial ingrowth under the surface of the displaced flap. So here you can see what I'm doing is just lifting up that flap and seeing what is there under it. A lot of epithelial ingrowth, obviously, because that was a very loosely adherent flap. So here the important thing is because we know that this flap itself is a very odd shaped flap. So this is one trick that I find very useful, using the endo illuminator to kind of find out the edges of the flap, because this is not a complete flap. This is just a partial flap which was created, and you want to kind of align it back to the right orientation once you're done. So you see the endo illuminator really helps you in identifying the edges of the stromal cut. And what I do is go ahead and make those aligning marks. And as it was just mentioned in the discussion prior, you can have very loose epithelial tags there. So that's the edge of the free cap, and then there's a little bit of epithelium that is kind of connecting everything in place. Obviously, not much use of retaining that epithelium in place. So what we do is scrape off all that epithelium and remove also all the epithelial ingrowth from the cap undersurface, as well as from the bed, and clean up the entire epithelium, not just under the flap, but also on the edges of the bed. So once that's done, what you do is you do this with a number 11 blade. So here you can see I'm doing it with a Mirocell sponge, but you also go ahead and do it with a number 11 blade. And I've gone ahead and marked the edges of the cap, and then you go ahead and replace that. So this is a complication where you've got a displaced flap along with epithelial ingrowth, and these have to be managed also. Again, now you can see what I'm doing is stretching it into place and using that endoilluminated light to make sure that the flap is completely aligned and put it back in place. Of course, after doing the striae test, which kind of lets you know that the cap has stuck in place. I also put fibrin glue along the edges, which Dr. Mahipal just mentioned, just so to make sure that there's no recurrent epithelial ingrowth under the flap. That's the striae test, which Dr. Gaurav just mentioned. I waited for sufficient time. I think I waited for almost 7 to 8 minutes in this case to make sure that the thin cap was attached properly to decrease the risk of a recurrent epithelial ingrowth, and also applied fibrin glue all around, again to decrease the chances of a fistula forming and leading to a recurrent ingrowth. So we've got this picture 2 months later. And quite an improved topography, and you can see again the on retroillumination the margins of that displaced cap. 4 months later, this is how she looked, and we thought that it was time to go ahead and do a treatment for the eczema, for the myopic correction, which had never been done for her in the first place. Of course, we do a PRK, so using epithelium to remove using alcohol to remove the epithelium, peeling it off carefully. And not using a rubbing movement of the forceps because you don't want to displace that flap which was adherent. And once you've done that, you can actually see the borders of that original displaced cap there. Go ahead and do the eczema. And this is the patient 3 weeks post-operatively, uncorrected visual acuity of 6.4, and did very well. I'll show you a couple of more videos. Here is a patient, this will probably just skip through because some of this is similar to what Dr. Sujata just showed, who presented with macrostriae as well as with epithelial ingrowth. And here is again a place where you need to mark the upper surface of the cap as well using an irreversible letter. And also you can use the endoilluminator to make out which side is up. You can again see lots of epithelial nests underneath that cap with also a displaced flap. And I've also got alignment marks. You can see that displaced flap is completely gone and lying over the conjunctiva. This patient had undergone two washes or replacements of the cap, and then she was referred here for management. So what I'm doing now is lifting up that flap, and you can see this is basically a nasal flap which has been created. Remove all the epithelium again using a Levin blade as well. So this has to be done from both surfaces, the undersurface as well as the oversurface. And just as Dr. Mahipal just mentioned, I've also removed it from the top of the cap and using hypertonic solution to swell up that cap to get rid of the striae. And once that's done, we see that this cap really looks much better now. And we go ahead and put it back in place. Also use sutures to prevent, to get rid of all the striae, and at the same time use fibrin glue to get rid of the chance for any fistula remaining there and thereby leading to a recurrent epithelial ingrowth. So here we've kind of used all the techniques that can be used for this patient. And basically we got a very good result. This was a patient post-operatively. I think I also have a retroillumination picture. Yes, that's it, which shows that even these very bad striae and epithelial ingrowths can really have a very good visual outcome. This is after the suture removal. So here's another epithelial ingrowth. This was in a smile patient, and this has happened at the edge of the incision. What I did here was use the circle procedure to kind of convert that smile interface into a cap, into a flap, the cap into a flap. So what I've done is that part of the flap is then raised up, and of course you scrape it off from both sides and then replace it, applied glue on the surface, and placed a bandage contact lens. Can really have lots of management for epithelial ingrowth. As you know, the basic principles always remain the same. You need to scrape off all the epithelium and then make sure that there are no fistulas that are left behind which could cause a recurrent epithelial ingrowth. So I think that would bring me to the end of my presentation. And there's of course the YAG laser also, which is very much spoken about for this condition. I don't have any personal experience with it. I'd like to know if any of the faculty does have any experience with the YAG.
Thank you very much, Dr. Soosan. I have a wonderful talk. A question here is, would any of you prefer using isopropyl alcohol, or would you think of using MMC besides just doing the epithelial debridement and all the other things which she said? Clearly, she has not used.
Yes, I think I would prefer to use 0.02% mitomycin C for 20 seconds in all these cases. I hope, Soosan, these are not yours. All the cases are referred. I hope there are too many epithelial ingrowths.
No, ma'am. Referred cases, of course.
Yes. Yeah, many of them
Yeah,
are.
I would feel more comfortable using 0.02% mitomycin C, and that is what we.
Yeah. Even I have used mitomycin C at all times, but anybody has experience of wanting to use isopropyl alcohol instead?
I use 20% alcohol because
Yeah,
I
okay.
feel de-epithelializes the cells. And even if you leave behind something which you're not able to see, some epithelial nest, then it doesn't at least proliferate in more. So I've done a couple of cases with 20% alcohol.
Yeah.
Used for LASIK, no, the same thing.
Yeah. So have any of, yes, Dr. Mahipal.
You can use both.
Yeah.
So both can be used, and the other thing that is very important in this is that you can also stain. So those are the things to delineate the whole thing. But Susan, I think it's a valid suggestion that you should use mitomycin C. That's very important. And at time, sorry, yeah.
You use alcohol sometimes, but I've not used mitomycin C so far. So probably that is a good suggestion.
They tend to regrow.
Alcohol also, I do use it with a little bit of caution because too much of strong alcohol has been reported to cause complications. So I think what Dr. Sujata ma'am said about 20% alcohol.
It is 20% alcohol.
Fibroblasts and all are addressed with mitomycin. So
whenever you have to lift a flap to remove the epithelium, the chances of having a recurrence of the epithelial ingrowth goes up very high. Therefore, using mitomycin C, and if there is a lot of removal that you have to do, then glue and then bandage contact lenses.
We have personally used mitomycin C, but I tend to agree with Sujata in the sense that, as far as toxicity to the epithelium is concerned, maybe diluted isopropyl alcohol at 20% is a better choice, because mitomycin C is more for preventing fibroblast proliferation, and maybe this might be a better choice. But excellent videos, Susan. Just one point is that always look for the track also, especially sometimes if you do not have something growing from the edge of the flap, but you have a central island, then often there is a track which is leading on to the island, and removing that track is also extremely important to avoid recurrence.
Yeah, of course we do that, sir, with fluorescein staining. When we do that, we can kind of see that track, and that is of course addressed. I think the sutures and the glue go a long way in addressing that track, because the glue actually seals it off while the epithelium is healing over it. So
yeah, but I think a little devitalized flap.
More than suturing, the best way to stop epithelial ingrowth is actually glue, fibrin glue around it, because it creates a proper seal all around, and it prevents the epithelium from regrowing again.
Has anybody tried using YAG? I think some very low energy YAG I've heard of being used.
It has been reported, but I haven't used it.
I've used in a few cases, and in I think we did it in about 3 cases. Two patients it worked well. It took time. In couple of cases actually we did very low energy over 2 or 3 sittings, and sometimes it works well to kind of it helps in stopping further ingrowth as well, and in one case it actually resolved a little bit as well. But frankly, there's no technique that I can describe which will work well, because it's like hit and trial kind of a thing. Yet maybe somebody else who has more.
Then I have a question for you. All the epithelial ingrowths that you showed were in the interface with a normal flap or with flap stria. I think it gets very tricky when you have an epithelial ingrowth in a buttonhole flap, and that is sitting right in the center.
Yes.
Have you had the chance to address such cases, or how would you?
No, I really haven't come across. I mean, I haven't had to handle personally epithelial growth with a buttonhole. Yes, it does make things much more difficult, because you don't want to. Generally, buttonholes are central over the visual axis, which creates it much more headache, because you need to make sure that you don't damage the flap or the cap or anything of that sort. And also lifting up that again is a bit of a problem, because again you have a chance of an epithelial growth from that. I really don't have much experience, but I guess I would kind of use the similar principles and put in glue. You can't put sutures there obviously, because it's the center, but I would kind of make sure that I do the stria test, make sure that it's completely adhered, and then I would still take precaution and put glue and put a bandage contact lens.
Yeah, thank you. We have a number of speakers, so we'll go on to our next speaker.